Okay, so after last time's topic, now we're looking at pelvic organ prolapse, which was actually talked about in step one. There were questions regarding this topic in step one, but first aid step one doesn't teach this at all. And then urinary incontinence, which was definitely taught in step one, and was very intimidating even in step one. If we go back to notes from first aid step one annotations, we can actually see where I annotated this into the book. So it's reproductive pathology. Not sure if it was, no, I think it was in reproductive physio. And I have some nice practice questions to really see how it all kind of pops up. Let's see where it is first. Prolapse. Oh, okay. I think, yeah, right here. So back in step one, there were random questions where they kind of wanted to talk about this, and step one NBME loved asking this stuff. So you can see I put some random pictures that I found online regarding the same topics to kind of show what it's all about. So prolapse is when something kind of moves from where it's supposed to be to a different place, right? So on the left here, you can see a normal uterus, right? So you have your normal uterus, which sits on top of your bladder, right? Pencil. So basically, this is a woman looking in this direction. So this is the front, right? And this is the back. So you have your rectum, the uterus, and then the bladder. This is the order in which all sits. So of course, you can imagine as the uterus gets bigger during pregnancy, it weighs down on the bladder, and it also can impede on the rectum when, especially when the patient is laying on their back. So now here you can see a prolapsed uterus where the uterus has moved down towards the cervix, right? So now this obviously is going to cause all kinds of problems. One, there's going to be pain in intercourse. Second, if she ever tries getting pregnant, or if she does get pregnant, then there won't be much space for the uterus to kind of expand, right? Because it can't expand in this direction, because the whole there, like this anatomy over here, this area doesn't really bulge much. Initially it'll move, and then when it does grow, it's going to basically take up and squeeze on the rectum, right? And then in general, it's probably going to end up being a failed pregnancy, and you can imagine there's going to be a lot of labor difficulty, because if the uterus starts to expand in this area, the baby can easily just plop out, right? And that's going to lead to a spontaneous abortion question, often preceded by someone who just got pregnant but is now having weird contractions and stuff. When we did the obstetric chapter here, we talked about the fetal stress test, right? All the different stress tests you can do for the fetus, and they're not going to come back in good results. So that's your prolapsed uterus right there. In this image here, you can see a cystocele, which is a prolapse of the anterior vaginal wall, right? So in this picture, the woman is looking in this direction. So this is the front, as you could tell, because the rectum is in the back, right? You have the butt over here. So here you can see the uterus is in the correct area, but the vagina has got this weird prolapsing happening right here, right? So now there's clearly going to be a little pocket here where, of course, things can accumulate. And anytime you ever have anywhere a pocket where things can accumulate, that leads to chances of infection. So that's going to be the main issue in that. And then, of course, lastly, you can also get a rectocele. A rectocele is where you have the rectum bulging. So you see how the rectum has bulged towards the front here, and same thing can happen here. This is actually more problematic as opposed to the vagina, because what's going to happen in the vagina one is urine can accumulate here, but even if urine is accumulating there, you know, certain finger maneuvers can actually get the urine out. But in the rectocele, right, feces is going to accumulate here. It's also going to harden, and both cases, the cystocele with the bladder and urethra, and then the rectocele with the rectum, both of those cases clearly thin out this exit path of the vagina, right? So now if she's pregnant, then delivery is going to be significantly difficult because the pathway out is already sealed off so hard that you really need to deal with all these issues. Questions on these topics will always show with very vague symptoms. So the way to answer these questions is going to be looking for a lack of certain other symptoms, right? So you would basically cancel out answer choices based off of the lack of symptoms relevant to those answer choices that are wrong, right? And then you'll imagine that the only thing left would be any other answer choice, and of course they'll have to have the answer choice related to either a prolapsed uterus, cystocele with the bladder impeding the vagina, or the rectocele with the rectum impeding the vagina. Right? So those are your prolapsed organ topics here. So pelvic organ prolapse. Risk factors for pelvic organ prolapse include vaginal birth, previous vaginal birth, genetic predisposition, advancing age, prior pelvic surgery like a hysterectomy, connective tissue disorders, which obviously weaken the things in the pelvic area, and increased intra-abdominal pressure associated with obesity or previously having long-term chronic constipation, which causes straining to defecate. Presents with the sensation of a bulge or a protrusion in the vagina, right, which we just looked at. Urinary or fecal incontinence, depending on which organ has prolapsed, will be present, and a sense of incomplete bladder emptying or pain with intercourse are also seen. The degree of pelvic prolapse can be evaluated by having the woman perform the Valsalva maneuver while in a lithotomy position. So we're going to see more of that. Right, so here in this picture, they're showing you prolapsing of the actual uterus, and then in the other images that we looked at on the first aid book, we saw the cystocele as well as the rectocele, which can mimic the symptoms of a uterine prolapse, right? So here there are questions to kind of better understand what that's all kind of going to require, right? So the first thing we have here is this table from UWorld definitions. So you have cystocele, which is the bladder, rectocele is the rectum, enterocele can also occur. So that's going to be, you see how the small intestine in the normal picture, the small intestine is all up here on top of the uterus. So this can also, because of really bad straining, possibly other abdominal surgeries regarding the intestines and anything else that was messing around with the intestines, it can also cause the intestine to move, pushing where it's, into places it's not supposed to be. Procedentia and apical prolapse, where the uterus and vaginal wall have prolapsing, like this one right here. So that's your uterine prolapse. It moved apically. Right, so this is also called procedentia. Procedentia is when it's prolapsed so much that you can literally just touch the uterus by just putting your finger right there in the vagina, not even too far in. Right, so this is why there's going to be a lot of intercourse pain. Risk factors, as we just saw, obesity, multiparity, previous abdominal surgeries, chronic constipation, all those other things. And then management is going to be very simple. Unless these simple managements can't handle it, then you have to do a surgery. And so weight loss, pelvic floor exercises, and vaginal pessary. And we're going to see in this question, you have both answer choices, pessary and surgical repair, right? Both of which are answer choices for management. This is basically the mainstay of all CK questions, right? You get multiple correct answer choices, but one is a better answer choice than the other. So here we have a 74-year-old woman, G5P5, so she's got multiparity. She's given birth 5 times, and now she's significantly old. So that obviously makes her weaker as well. Comes to the office due to vaginal spotting and discharge for several months. Now, right there, as you read that first thing about your patient, you should imagine there aren't many reasons someone 74 years old could really have vaginal spotting. She's obviously postmenopausal. She very unlikely that she would have endometriosis or adenomyosis at this age, so it can either be something really, really bad, like cancerous, or something else, which we're going to learn about as we keep going. So you read the rest of this. Now it says she reports a mass coming out of her vagina. She is now having difficulty defecating. Increased straining causes the mass to increase in size. She has hypertension, diabetes, NYHA class 3, heart failure. Her last hemoglobin A1C was 11.8, so her diabetes is basically not that well managed. She had 5 spontaneous vaginal deliveries and has no history of abnormal pap smears or anything like that, so it's very unlikely that it's cancer, cervical cancer. She has a 40-pack year smoking history. Blood pressure is bad. Her A1C is bad, right? So we're going to highlight those things. Oxygen saturation, 89% of room air, not the worst. She's also very obese, right? That's terrible. That's way over the 30s. Now she's in 40s, right? 41. Cardiopulmonary exam reveals decreased breath sounds bilaterally, which could be relevant to her extensive smoking history plus obesity, right? So we're not thinking of these, right? We're seeing multiple problems in her already. Before we even got into the physical exam, we already see she has a lot of unmanaged or poorly managed problems. The abdomen is non-tender and has no palpable masses. So that already rules out adenomyosis, where the whole thing would be bigger, the whole uterus would be bigger. Endometriosis rules out leiomyoma, which would have tiny masses and a non-uniform uterus. Pelvic exam reveals the cervix at the level of the vaginal introitus. So that right away gives you the answer, right? The cervix has come down to the vaginal entry point. The cervix is supposed to be much further in. So that's basically diagnostic right there, right? The vaginal mucosa is thin with multiple areas of excoriation and erosion, which is pretty typical of this age and her comorbidities. Ultrasonography reveals a thin endometrial stripe, which tells you it's not endometrial cancer. What is the best next step in her management? So now, pessary fitting or surgical repair? First of all, let's assume that surgical repair, in another country, surgical repair may have been the answer, especially in countries where money is looked at with more value than a patient's well-being. You're going to tell the patient to get surgery. You can definitely do surgical repair here, put it back up, fix it up, and then she'll be fine, and throw a hefty bill at her. But is it really worth doing surgery for a 74-year-old woman who doesn't ever plan on getting pregnant again? No, right? It's definitely not worth it. And on top of that, given all her comorbidities, doing surgery for her is not going to go too well. She's still a heavy smoker. She's got really bad diabetes. She's got unmanaged hypertension, and she's super obese. So in America, we know we cannot do surgery, right? All of us need to know this. We cannot do surgery for someone, even if she was at a good age, someone who has bad diabetes, bad hypertension, and obesity. This is going to be a very bad surgery, right? So even if you really did think that surgical repair would be the correct answer here, there's a lot of things in the question that clearly tell you it's a terrible idea to do surgery on her, right? Her blood is going to be super thin. Her blood pressure is going to cause a lot of complications. And then her obesity is just going to make surgery overall a terrible experience. On top of which, even after you finish the surgery, she's probably going to get the prolapse again because of all her comorbidities that are not going to be changing anytime soon. So pessary fitting was the correct answer here, right? Uterine procedentia is a form of pelvic organ prolapse in which the uterus and the anterior and posterior vaginal walls herniate through the vagina, coming all the way to the front like that. This is why they're saying that her cervix is right there at the entry. And they describe that cervix at the level of the vaginal introitus. POP occurs due to weakened pelvic support and more intra-abdominal pressure, which are exacerbated by increasing parity, obesity, and advancing age, and she has all three. Typical symptoms include vaginal pressure and the bulging mass that increase with Valsalva maneuver, because obviously every time she's going to do Valsalva and increase pressure in her abdominal cavity, she's going to push this down even more. POP may be asymptomatic and doesn't require treatment. Very important to remember this, right? Does not require treatment. Doesn't always require treatment. Very important thing to remember. Even though it's causing her some issues and it's definitely annoying, it does not always require actual treatment. You could just do management, give her something that'll make it feel better and less problematic and allow the other systems to work well, so no constipation, etc., and things should be okay. However, when patients have symptoms such as pelvic pressure, bowel bladder dysfunction like her constipation and difficulty urinating, treatment is indicated and treat with either surgical or non-surgical management, and both are equally efficacious. Thus, treatment depends on patient preference and surgical risk, and that's what we just talked about, right? She is a poor surgical candidate due to her age, obesity, heart failure, which I forgot to highlight this part right here, and diabetes, right? Thus, pessary fitting can help support the prolapsing organs and restore anatomy to resolve her bowel and bladder symptoms, and she should be just fine after that. Right? So this is how you're going to pick these answers. Usually that will be the most commonly chosen answer choice, right? Because you have to remember, telling someone to lose weight or do exercise, you can tell patients that all you want, you can prescribe that all you want. It doesn't mean that patients are going to carry that out, and then in a couple weeks they're going to come back telling you the problem is still there, right? So that's not going to work too well. in this question down here, is similar kind of scenario. So we have a 63-year-old woman comes to the office for a routine annual exam. So that tells you, remember, anytime someone comes in for routine shit or just comes in for a regular checkup, it tells you that they're not having any crazy problems, right? And they further tell you that she feels well and has no concerns today. She underwent menopause at age 50 and has had no episodes of vaginal bleeding. She exercises multiple days a week and has no urinary or fecal leakage. Her BMI is pretty decent, under 30. Vitals are fine. Cardiopulmonary exam is fine. So she's the exact opposite of our other patient, right? She's doing much better. She's handling her aging extremely well. The abdomen is soft and not tender, without palpable masses or hernias. On pelvic exam, vulvar atrophy is present and the vagina appears, I'm not sure what this word is supposed to be, maybe ample, and has minimal rugation but no lesions. I'm really not sure what this was supposed to be. This is a typo, but I'm not sure what that word was supposed to be. But either way, whatever they're describing here is pretty normal for someone who's 63 years old, right? The vulvar atrophy is a given. Cervix appears normal as well, so no cancer, has no lesions or discharge. Valsalva maneuver, there's a bulge of the anterior vaginal wall, right? Bulge of the anterior vaginal wall into the introitus. Post-void bladder and renal ultrasound are normal. So after she urinates, her bladder is actually emptying pretty well, and her kidneys are working fine. What's the best next step in her management of her pelvic organ prolapse, which they kind of gave away in the question, but you know that if it's bulging on Valsalva, that is pelvic organ prolapse. So now at this point, when you see an answer choice like reassurance observation, and then the other answer choice of pessary placement, you really have to, reassurance and observation always going to be a little bit of a scary answer choice to pick. You won't always be 100% confident when picking it, but this is the job we have to do sometimes, right? She has absolutely no symptoms whatsoever. So at this time, we would just reassure her and observe. And if anything, we would have told her to do these things, right? Lose weight and do pelvic floor exercises. But she's already got that down. Her BMI is good. She does exercise and she has done a pretty good job taking care of herself, right? So reassurance and observation would be the thing. If later on she comes in saying that now that bulge of her anterior wall is causing problems, then you would do pessary placement, right? Asymptomatic, incidentally diagnosed issues of pelvic organ prolapse is something you don't need to do anything, right? Do not require treatment at all. Nothing needs to be done. Our previous patient did need treatment, and it was very evident she was going to need some kind of treatment because she had so many other comorbidities, the heart failure, diabetes, hypertension, all poorly managed, and obesity. So her lifespan is already looking pretty bad as well because of all of that thing. Right? Symptomatic patients with complications can do Kegel exercises, have pessary placement, or do surgical repair if the condition does not improve after trying Kegel exercises and pessary placement. Surgery is the last step you try. Right, so very straightforward topic, very easy topic, very simple to identifying questions, no reason to mess it up. And as far as learning what the next step in management is, this is why you do practice questions, and when you do these practice questions, you learn it. Right, so here we are learning it. And that's kind of all they're really going to keep talking about, right? So supportive measures include a high fiber diet, weight reduction, obese patients, and limitation of straining and lifting. Pessaries may reduce prolapse and are helpful in women who do not wish to undergo surgery or who are chronically ill, such as our 72-year-old with heart failure. Surgical procedure depends on where the prolapse is located. Vaginal vault prolapse is treated with hysterectomy and with vaginal vault suspension. So you would just take the whole uterus out. There's no reason in putting it back in on a patient with prolapse if they're not looking to get pregnant ever. If this patient was even actually looking to get pregnant in the future, which is a question you can definitely get, there's someone who has a history of prostodentia and you fixed it with a pessary placement and now they're going to try to get pregnant, it's very unlikely they'll be successful, because if the uterus is slipping out when it's empty, then you can only imagine how easily it'll start falling out when it's full and heavy with the whole baby in there, right? Anterior and posterior vaginal wall, you can just repair the wall, right? So if it is either vaginal walls that the problem is in, you could just repair that, and that's called colporoscopy. So that's not very commonly seen. I haven't seen any questions on it either. But again, these are going to be surgical procedures, which you're going to do after trying everything else that is non-surgical. Next topic is urinary incontinence, another hard hitter in step 1. So many things regarding this, right? There's stress, urge, and overflow incontinence, and there's a bunch of practice questions here to really get down what's happening. So let's take a look at what's up with them, and we'll go look at the step 1 version of it all too to get a good full understanding of it, because they don't talk about it too much here. They're assuming you mastered it in step 1. The involuntary loss of urine caused by either bladder or sphincter dysfunction. Now, it's not urinary incontinence if they just have urinary urgency or they need to keep peeing, any of those things. It's incontinence when there's leakage, right? So they have to tell you that there was involuntary urination where you could not stop yourself from urinating. It's the inability to stop yourself from urinating. That's what's called incontinence, right? Lack of control. This table down here is going to outline and distinguish all the different things, and they have the diapers mnemonic. Now you have to exclude a fistula in cases of total incontinence. Total incontinence is where you're urinating or defecating without really having any control over it, right? So that must mean that there's a high chance of a fistula where there's a connection that occurred. This is actually not that rare. A fistula can occur when you try to do surgery. Actually, it can occur during childbirth when you actually try to do an episiotomy and you cut down from the bottom part of the vagina towards the rectum. So when you try to do that cutting down, you may have made a tiny incision, but if the baby was born to a mom with gestational diabetes and the baby is very significantly large for gestational age, then on its way out, it can take that tiny cut you made during the episiotomy and make it much bigger. And if that cut gets bigger, then of course you can imagine, let's say you have the vagina here, and of course the rectum is right under it, right? If the baby's coming out, you're going to try to do episiotomy with the vertical cut over here, right? Just to make this opening bigger to get the big baby out. You get the baby out, and in getting the baby out, maybe the cut became even bigger. So you can see how eventually it'll cut and break into the rectal sphincters, right? And inside, it can rip even more and connect with the rectum, right? So that's a fistula that can definitely form. And this is generally the only thing I can think of where this kind of a question would present. It would have to be a baby that's so big that the expansion of the vaginal opening wasn't enough. And when you did that episiotomy, you further increase the chances of a fistula forming. Look for neurologic abnormalities in cases of urge incontinence, such as spasticity, flaccidity, or rectal sphincter tone, or a distended bladder in overflow incontinence. And we're going to see what these are all about, because there's a lot of nervous system connections related to urination. Diagnosis and treatment: obtain a urinalysis and urine culture to exclude any UTIs. Tell them to keep a voiding diary. This is actually often an answer choice. Consider urodynamic testing, which is also often an answer choice. We saw earlier when we did some questions, I believe in obstetrics, where urodynamic testing was an answer choice and people picked it, but it was not relevant because the question wasn't about urinary incontinence, right? Urodynamic is literally about the dynamics of your urination. So that's relevant here, not for some of the things we looked at before. Serum creatinine to exclude any renal dysfunction, and serum creatinine could be high. People can have renal dysfunction, but that doesn't mean that they do not have urinary incontinence, right? They could have renal dysfunction and urinary incontinence. Obtain a cystogram to demonstrate fistula sites and descensus of the bladder neck. And then here they're going to show you all the different subtypes, and that's all they really do for it, because then after that you go into pediatric gynecology. So they break it down for you in a very simple manner. They have the total incontinence, where there's a history of urine loss, right? Uncontrolled loss at all times and in all positions, irrelevant of coughing, running, etc. There's a loss of sphincteric efficiency, maybe due to previous surgery, nerve damage, or cancer infiltration. And there's going to be an abnormal connection between the urinary tract and the skin. So now the urine just comes out all at once because the skin doesn't have a sphincter to it for you to control, right? So how do you fix this? Well, you have to do surgery. If it's a fistula, there's nothing else you can do but surgery. Right, so this actually ends up being the easiest question on urinary incontinence. Then you have stress incontinence. So stress incontinence is relevant to some kind of pressure, right? Increased intra-abdominal pressure causes urine loss. Maybe when the patient is coughing, sneezing, lifting, laughing too hard. Anything that you would do that would flex your abs and cause pressure in intra-abdominal cavity is going to press down on the bladder and urine leakage happens. Urethral sphincter insufficiency caused by laxity of the pelvic floor musculature. common in multiparous women or after pelvic surgery. So what do you do for them? Mainly if their age and other comorbidities allow you to, mainly they're going to do Kegel exercises, and you could do a pessary placement. All right. If none of that works, then there's something called the urethral sling procedure. They don't have a picture for that, so let me find and post one here. Urethral sling procedure, and this is something you should do for basically everything you ever see that doesn't have an image with it and you don't know how it works. But it is exactly what it sounds like. It is exactly what it sounds like. It looks like this. It's actually a sling that you're gonna put there. So you can see there's a tape or a sling that they've attached to the urethra, right? So that it can be basically tightened, so urination won't occur that easily, right? But when they sit down, the sling loosens up a little bit. So when they sit down to urinate, then urination can occur, right? If your bladder opening is very weak, then even while you're just standing, as soon as a little bit of urine comes down the ureters into the bladder, it's going to start leaking out, right? And that's a problem. So this is the sling procedure. I'm not sure how commonly it is done, but it's one of the things that is an answer choice here, so you want to make sure you know it. All right, so again, now you can see stress incontinence. One, pretty easy to diagnose because it has to be a one-to-one connection between some kind of intra-abdominal pressure and urine leakage. And then treating it is all about helping stop that leakage. Next one you have is urge incontinence. Now urge, here they tell you etiologies include inhibited contractions, local irritation, and CNS causes. Many different things that can cause it. But generally what is here is you have an urge, which is perfectly named here. So there's a strong unexpected urge to void that is unrelated to position or activity. Right? You keep getting the urge to urinate. Detrusor hyperreflexia or sphincter dysfunction caused by some inflammatory condition or neurogenic disorders of the bladder. Right? So there's detrusor hyperreflexia. The detrusor muscle is working very, very hard and you keep having to go urinate. Right? And if you don't go, if this patient doesn't go because they're in some kind of, maybe they're at church and they can't go right now because the sermon just started, or maybe they're attending some event and they can't go to the bathroom right now, etc., etc. Any case that doesn't let them go, they'll start leaking. All right. So how do you treat these people? Same thing again, pelvic floor exercises, which is the Kegel exercise, bladder training, but now you're going to have pharmacologic interventions. See, the issue of detrusor hyperreflexia can be stopped with anticholinergics. So the way I remember this is cholinergic stuff is parasympathetic. Parasympathetic is all about rest and digest, and rest and digest entails urinating. So if you take an anticholinergic, you stop urinating, right? This was taught basically very well, the concept of how acetylcholine is related back in pathology, actually back in pharm, when we looked at the key differences between anticholinesterase poisoning versus atropine overdose. Remember, anticholinesterase poisoning meant that you had something that stopped your cholinesterase. So if you don't have any cholinesterase, you're going to have too much acetylcholine. If you have too much acetylcholine, you cannot stop urinating. Right? You can't stop diarrhea either. You're just doing full-blown everything that would be regarding resting and digesting. Right? Bradycardia, heart rate is very slow. Right? Digesting, vomiting, diarrhea, urination. That's all anticholinesterase poisoning. So how do we fix this? You fix this by giving the person atropine. But if you have atropine overdose, then the opposite of resting happens. So now you have dry as a bone, red as a beet, right? Everything is opposite of resting and digesting. Now they're going to have elevated heart rate, right? Decreased gut motility, so no more diarrhea. Instead, they have constipation. Decreased urgency, right? Now they can't pee at all. So atropine essentially would be an answer choice of something you would give this person to stop their urge incontinence, right? You don't always opt to go with medicine. If you think that the question scenario of the patient is something that can be dealt with using pelvic floor exercises and bladder training, then that's the answer choice you should go with. Right? This is going to be based off of your own best clinical judgment. If you don't think that they can handle it and that exercise and stuff are not going to fix it, then you have to give atropine. And also there's beta agonists such as mirabegron that can be used. This is a very new medication. In fact, even here, it was very new, mirabegron. Right? This wasn't always in first aid for urinary urge incontinence or an overactive bladder. Right? It's a beta 3 agonist. If you look at your beta blockers real quick, well, these are beta blockers. We need our beta agonists, sympathomimetics. Oh, these were the sympathomimetics, right? Yeah, right here. So these are all your alpha and beta agonist medications, and mirabegron is a beta 3 agonist, right? So remember, with all your alpha and beta stuff, most of these were actually for sympathetic activity, but beta 3 is anti-urination, right? So it's going to help them with the urge incontinence. A very important thing. Excuse me. Back in step 1, urinary incontinence was discussed in renal, right? And they didn't really teach it that well here either, but thanks to UWorld, we had a really good idea of what we needed to know, right? The UWorld images here, what we're looking at, are going to help you understand the anatomy of the bladder and know what's being discussed when we say some of these muscle names. So you have your detrusor muscle. The detrusor muscle is basically the muscle surrounding your bladder. So when the detrusor muscle contracts, it squeezes your bladder and urine will come out, right? Then you have the urethra, which is the path that urine is going to take, and you have your sphincter muscles, right? So you can see your pelvic floor muscles, which are the external urethral sphincter, and then the orifice, which is where it's going to come out. So you have an internal urethral sphincter and an external urethral sphincter, both of which are encompassing the urethra in between of it, right? So that's your general bladder anatomy right there. And then here you can see the various receptors and plexuses that are involved in managing how you urinate, right? At first it looks very complex, and UWorld made this picture, after which first aid made this picture. So this is all pretty new for first aid. So you can see the connections, right? So the first thing I'm going to look at this one, pelvic nerve. The pelvic nerve is the one that was related to your mirabegron, the beta agonist. Sorry, not the beta agonist, the acetylcholine stuff. It's an M3 receptor, right? Parasympathetic. Pelvic nerve is parasympathetic. Parasympathetic stuff for acetylcholine, and this uses your M3 with acetylcholine to help you, right? So this pelvic parasympathetic nerve, this is actually going on to your detrusor muscle, right? So your detrusor muscle here is M3, right? M3 with the pelvic nerve. That's what's happening right there. Your hypogastric nerve, that's a sympathetic one. It's part of the sympathetic ganglion, my hypogastric plexus. This is the one that uses your beta 3 receptor all the way over here for the same thing, the detrusor muscle. The hypogastric nerve also has connection to your internal urethral sphincter, which uses alpha 1 receptor. So that's another place you can use medicinal therapy. We're going to see that soon. And then the last thing is your somatic input from the pudendal nerve, right? The pudendal nerve is all the way at the bottom for your external urethral sphincter. This nerve often gets injured during delivery. We can actually anesthetize this nerve during delivery, and then during the anesthesia procedure, if they tell you in the question they did that, during the anesthesia procedure, this nerve can actually get injured such that the external urethral sphincter doesn't work so well, right? So all of these are case scenarios where you can of course end up having urinary incontinence, right? So you're seeing your nerves, the various receptors that are responsible, and how they all work. So I wrote here external urethral sphincter, internal urethral sphincter, and the detrusor, right? All of which are going to be targets of things we're going to try to utilize for therapy. In general, I wrote over here, right? Midodrine. Midodrine is also an acetylcholine you're going to have to watch out for. Midodrine is an alpha 1 agonist that can contract your urinary sphincter and detrusor and help with stress incontinence, where the bladder sphincter may be underreactive, right? The bladder sphincter doesn't work so well. So every time you cough, there's leakage like this. Right, so every time there's pressure on the top, there's leakage. So what do you do for this person? You give them midodrine. It'll make the external thing tighter, and you're not going to urinate that easily. You're not going to leak that easily. There's also duloxetine. This is a very rare answer choice, but they can put this as an answer choice just to be assholes, basically. This is an SNRI, right? Serotonin norepinephrine reuptake inhibitor. That can also increase noradrenergic and serotonergic activity in the sacrospinal cord and increase external urethral sphincter activity, thereby tightening this to stop you from urinating, right? So that's kind of what we're seeing there. Those are two medications. In a healthy individual, bladder wall relaxation due to stimulation of beta 3 receptors in the detrusor muscle allows storage of urine. During the storage phase, contraction of the trigon and the sphincter muscles due to stimulation of alpha 1 receptors at these sites maintains continence. bladder wall contraction due to stimulation of M3 receptors by acetylcholine in the detrusor muscle, and reflex inhibition of the trigeminal sphincter allows for micturition to occur. So basically, beta 3 and alpha 1 are keeping you from urinating, and M3 will allow you to urinate, right? So if you want to stop urinating, you want to upregulate your beta 3 or alpha 1 receptor. Those are the guys that will stop you from urinating. And you want to stop the M3 guy, right? You want to stop M3, you want to upregulate beta 3, upregulate alpha 1. Because those things are sympathetic nerves, right? Sympathetic activity is fight or flight. So you don't urinate when you're running or fighting. These are all drugs that are going to be related to urgency incontinence. Right? You can use them there. So if they tell you for muscarinic M3 antagonists to stop the acetylcholine activity, you could use tolterodine, oxybutynin, sulfenacin. There's a bunch of M3 antagonists, which is what makes this a difficult question, because if you don't know all the M3 antagonists, it can be a little difficult to pick an answer choice. But all in all, you should know some of the other answer choices that are in the question and realize that those are not anti-acetylcholine, and then pick the one that must be. The newly developed beta 3 agonist mirabegron helps, right? And then the last thing here, muscarinic M3 agonists like bethanechol are parasympathetic mimetics used to treat urinary retention. So now the last one we haven't looked at yet is number 3, overflow incontinence. This is different from the first two. In this one, you're not urinating. You're unable to urinate. Your bladder fills up, and it's so full now that there's overflow and it leaks. The bladder has no more space, so urine just leaks out. Right? Chronically distended bladder with increased intravesical pressure that just exceeds the outlet resistance, allowing a small amount of urine to dribble out. So in this person, theoretically speaking, their sphincters are working fine, right? Their sphincters are working great actually, because the bladder is super full and it's not coming out. But now it's so full for chronic moments that it has started leaking. So what do you do for them? Again, remember, you always want to avoid medicine. You always want to avoid surgery. So first thing you're going to try is urethral catheter, right? You're going to put the catheter in, and boom, all the urine is going to come out. For them, you'll notice that usually when they do go urinate, there's going to be a high post-void residual volume. So after urinating, there's a high residual volume. Every time they go urinate, a lot of urine just got left behind and didn't come out of the bladder. So you tell them to do timed voiding. This is also going to be an answer choice. Very dumb and annoying, but you're going to have to pick it. Where you're going to tell them, just like you teach kids, to go urinate as often as they can, right? Not, in my opinion, not the best thing to advise a patient, but again, based off your clinical understanding of questions, when you see this in a question, that may be what you'll have to pick. And then lastly, treat any underlying disease that may be causing their bladder to not work, right? So in overflow incontinence, you actually want to upregulate the M3 thing, which will be the parasympathetic urination, right? So here you use muscarinic agonists rather than muscarinic antagonists. You use muscarinic agonists like bethanechol, which had a mnemonic in step 1. Bethany, call me to turn on your bladder, something like that. Right? Parasympathetic mimetic used to treat urinary retention and overflow incontinence due to underactive detrusor. The detrusor muscle, the muscle that is encompassing the whole bladder, is not working very well. It should have been squeezing already when it was about 75% full. As soon as the bladder is more than 50% full, you will get the sensation to go urinate. Right? And these people, that sensation is there, but the activity of micturition is not there. Right? The Zosyn alpha 1 blockers are also great for patients who may have BPH. Right? This is going to be a male patient who may have such a big prostate that it's actually stopping exit. Right? So it can help them as well. So those are all your different medications, and these are 3 different questions here to show you exactly how all 3 of these cases presented back in step 1, where all you had to do was identify the problem and choose a solution. 48-year-old woman comes with a 6-month history of involuntary passage of a few drops of urine when sneezing or coughing. So that first sentence already tells you everything. First of all, it's definitely incontinence because she has involuntary passage of urine. It's leakage, right? She can't control it. That is urinary incontinence by definition. And then it occurs with sneezing or coughing, so it's a stress incontinence. Super simple, right? 48-year-old woman with stress incontinence, right? Drops of urine related to coughing. She has a history of hypertension and diabetes. She is married and has 4 kids, so she's delivered a lot of times, which of course also weakens the urethral area. External genitalia exam shows leakage of some urine from the urethra upon coughing. What is the most likely cause of her condition? Urethral sphincter dysfunction, of course, right? The the urethral sphincter, whichever one, internal or external, must not be working too well. That's why every time she puts pressure on the top, some of the urine just comes out, right? Because the exit doors, the doors are not locked that well. That's it. Very straightforward. Next question. 36-year-old woman comes to the office due to frequent urination since an exacerbation of multiple sclerosis 2 months ago. Now, in this first sentence, we don't know if it's incontinence yet. Frequent urination does not mean incontinence. Frequent urination means you just go to urinate over and over. But is it under your control or not? That's what determines incontinence. Most of her symptoms have improved with corticosteroids, which would be the solution for her multiple sclerosis, but she continues to have difficulty holding urine and on several occasions has passed a small amount of urine while going to the bathroom. So on her way, she is leaking some urine. Now it's starting to look a lot more like incontinence. She has no urine leakage during coughing or sneezing, so it's not stress incontinence, and her post-void residual volume is low, so it's not overflow incontinence where she's retaining urine. So then the only thing that's left would be the middle one, the urgency incontinence, right, where she is just randomly urinating when she doesn't really want to. What is the most likely explanation for her urinary symptoms? Well, she has multiple sclerosis, right? So she must not have the correct nerve plexuses here to actually control her urination activity. So it must be an uninhibited bladder contraction. Remember that bladder contraction, we inhibit it when we want to. If I'm in a meeting, if I'm teaching you guys here, if I'm going running, whatever it is I might be doing, if I'm in any case scenario where I cannot urinate right away, I am able to inhibit bladder contraction. But if that nerve is not working, then my brain cannot send the correct signals, and now I cannot stop bladder contraction, which is why her bladder just contracts even as she's going to the bathroom. She can't stop her bladder from contracting very clearly, right? Obviously. The issue is not that her sphincter is not good. That was definitely another answer choice here. But if her sphincter was not good, then it would leak even when she coughs because the door would be very weak. And if it was overflow incontinence, then she would have high residual volume even after she urinates. A lot of volume would be left behind. Okay, so this is just uninhibited bladder contraction. This is urge incontinence due to detrusor overactivity. Treatment is with an M3 antagonist like oxybutynin, which is going to decrease IP3 and calcium release, leading to decreased smooth muscular contraction. You're stopping her parasympathetic rest and digest acetylcholine activity, and you're stopping her from urinating because she keeps getting the urge to urinate, right? But her problem is not a leakage due to a bad sphincter. Her problem is the whole bladder, the detrusor muscle, is working too much, keeps contracting. So every time there's any urine in there, it just starts contracting. That sucks. Last thing, 42-year-old man. So now we have a male patient with a long history of diabetes, comes to the clinic due to frequent involuntary loss of urine. So involuntary loss of urine, incontinence. For the past several months, he has been having difficulty starting and maintaining urinary stream. So now that's actually concerning. Difficulty starting means that he can't even start urinating, which sounds a lot like this may be related to BPH. In the last 3 weeks, he's had 2 episodes of nocturnal enuresis, urinated in bed, and many daytime episodes of uncontrolled voiding without any sensation of a full bladder, right? So when it's not related to a full bladder, you can rule out the overflow incontinence. It doesn't look like he's urinating because of coughing or something, so you can rule out stress incontinence, right? So now we need to start thinking, what is the problem then? Because if he doesn't have a sensation of a full bladder, what could be happening? His other medical problems include chronic kidney disease and gastroparesis. What additional finding will be present? So you look through your answer choices and then you reevaluate what must be happening. So it turns out that this is overflow incontinence. He just doesn't get the sensation of a full bladder, right? He just doesn't get a sensation of a full bladder. See, you would rule out stress incontinence. Very obvious it's not stress incontinence, right? Because his urination was not related to increased abdominal cavity pressure, right? He doesn't have coughing leading to voiding. And he doesn't seem to need to go urinate, right? They didn't say that he keeps feeling like he needs to go. In fact, he doesn't have any need to go. He doesn't get the sensation to go. So the fact that he doesn't have a sensation to go means that his bladder keeps filling up and he doesn't even realize that he needs to go pee. And then it gets so full that it just leaks at night when he's least conscious, right? So when you reevaluate your answer choices and you look at everything that's left, it must be overflow incontinence and you pick increased post-void residual volume. In fact, Step 1 used to ask you the same thing that CK is asking. In CK, they would give you the same exact scenario and ask you what's the next best step in management. The next best step in management will be to check his post-void residual volume, because you're supposed to be developing a suspicion of what's wrong with him, and your suspicion should be that maybe this is overflow incontinence, because it's not urge, he doesn't have the urge to go pee, and it's not stress incontinence because he doesn't cough and pee. So then you would check for that. And in step 1, instead of asking you what's the next step in management, they literally just tell you what would you find if you tried doing the next step in management, which would have been to check his residual volume, right? So you get to see how all 3 of these case scenarios present, right? Last one here, 52-year-old postmenopausal woman comes to the office due to leakage of a few drops of urine with coughing and sneezing. Super obvious stress incontinence, right? She has no dysuria, urgency, or urinary frequency. She has had 3 spontaneous vaginal deliveries. Physical exam is notable for a mild cystocele. So she has a cystocele, which is the bladder prolapse kind of thing that we looked at. She is advised to perform exercises to strengthen her pelvic floor as part of her treatment for her symptoms. Which of the following structures is the most likely target of the exercise? So this was an asshole question that really just wanted you to know the anatomy of all these things. And turns out the correct answer here was the levator ani. Now, levator ani is actually not a surprising answer choice. This is actually taught in pregnancy questions very well. That is the muscle you strengthen when you do these Kegel exercises. So you do need to know that, and you see the levator ani answer choice, and you would pick it. In fact, some of these other answer choices that people picked, they must not have really thought how exercise works. For example, how could you do any exercise that would make your detrusor or external urethral sphincter stronger? I don't know of any exercise I can do that would make my bladder muscle stronger. And I don't know any exercise I can do to make my external urethral sphincter muscle stronger. There's no such thing. Right? Those muscles are in somewhat control of yours, but the only control you have on those muscles is to not contract them. Right? When we don't want to urinate, we can inhibit the contraction of our detrusor muscle. And when we don't want to urinate, we can inhibit the opening of the external urethral sphincter, so it stays contracted. But we can't choose to contract and non-contract. We only have control of half of that. Right? We can only stop urination. We can't truly start urination. The way we actually start urination is by stopping the stopping of urination, right? Because we're always stopping it. If you stop stopping it, you start urinating. So you can't necessarily actually start urinating. So it made no sense how these people chose external urethral sphincter or detrusor muscle. How do you exercise those muscles? Right? You really need to think about that before you pick one of these answer choices. The levator ani is a huge floor muscle, pelvic floor muscle over here, which you can exercise. Right? That one is the one that you do pelvic floor exercises for, and when that gets stronger, it helps. Right? You basically want to strengthen these guys so that they squeeze harder here, and she can stop peeing every time there's pressure on the top. So you see how you really want to avoid medication, right? That's kind of one of the other things here, right? And don't freak out from all the nerve system stuff. You know, this picture does a pretty good job breaking it down for you. Take your time understanding it. The first thing you need to understand is that peeing is parasympathetic. It needs acetylcholine. When you have acetylcholine, you will urinate. So if your patient has a problem where they're not urinating, aka overflow incontinence, then you turn on urination by giving them acetylcholine, beta-nicol. The other stuff is beta-3 receptors and alpha-1 receptors, which are adrenergic sympathetic receptors. Those are the guys that are going to stop you from urinating. So those are great for people who keep urinating without wanting to, such as in stress incontinence and urge incontinence, right? Where they just really need to pee for whatever reason, either because they coughed or because they have to pee. The beta-3 and alpha-1 agonist medications will stop you from peeing. Right, so those are the general concepts there, and over time you get better at it when you look at more pharm and more of the medications and practice questions. Right? So that's your urinary incontinence in a nutshell. You want to make sure you master these things today, since we've already talked about it right now, and you joined the session. And anyone watching the video later on, you want to make sure you master it the day you watch this video. Right? You don't want to come back to these topics every time. Every single day of dedicated step prep should go with ruling out topics, right? You're done with these. Done. Never need to come back to it. You're done. And by done, I mean you shouldn't get those questions wrong either. The only reason now you'll get a question wrong on urinary incontinence or pelvic organ prolapse is because either the question was worded really, really bad, and by bad I mean really, really rudely, really like hard question, or they did something new in her management, in their management. It could be a male too, where the answer choice was something you've never heard of before. But even then, you want to try getting good at picking the answer choices that you've never heard of before by ruling out the answer choices you have heard of and evaluating how effective those other answer choices would even be if you did them. So let's take a look at what's happening in these CK questions. Here we have an elderly 78-year-old woman brought to the hospital for urinary incontinence. So they're being real straight up with you. They tell it to you. It's urinary incontinence, but they didn't tell you which type yet. She has a history of Alzheimer's and has been living in a nursing home for the past 3 years. Now, this is pretty critical. A lot of the Alzheimer medications are actually relevant for acetylcholine. She requires assistance for most of her daily activities. She can indicate to the nursing home staff when she needs to use the bathroom. She has been less active for the past week and sleeps most of the time. She also has developed urinary incontinence, which she has never had before. She's somnolent but responsive to voice. She is disoriented but has no focal neurologic deficits. So being somnolent and disoriented is concerning, right? That sounds like in an elderly patient, there's something called the Beers criteria, which are all medications you should not give to elderly people because of adverse outcomes that can occur. So here it really sounds like either she's got something along like delirium, maybe, right? Very common thing with elderly patients. In fact, my best friend just became a nurse, and all he ever talks about, he loves talking about it, is delirium. Delirious patients, and not so much dementia patients, but delirious patients are a very common thing nurses have to deal with every day in the hospital. Elderly patients are known for this. It's called, in their terminology, the nurse terminology, is called sundowning. Sundowning is basically when the sun goes down, they all go crazy, right? And they start doing really weird delirious things. And when you have dementia already, delirium onset is even easier. And delirium is a huge psych topic back in step 1, huge psych topic here as well. Dementia is a neuro topic, but delirium is a psych topic. Delirium occurs in patients usually because of something else that's bothering them. The abdomen is soft and non-tender. Genitourinary exam shows a thin, pale vaginal mucosa with ill-defined labia minora, which is totally normal for someone this elderly. What is the best next step in her management? So if you understood that the somnolence and disorientation in a 78-year-old woman is very weird, and that she's in a daycare and all that stuff, if you understood that she must be having some level of delirium from something, then you would go order a urinalysis and culture to see if maybe she has a UTI. When you start looking at your delirium questions in psych, you'll see that oftentimes it is because the patient had a UTI like maybe 2 days ago. You gave them antibiotics, you fixed the UTI issue, but then something else happened. Or while they had this UTI, they were very, very delirious. And then you fix the UTI and the delirium goes away. Right? So that's kind of what happened here. This patient with dementia has acute urinary incontinence. Acute infections, especially urinary tract infections, are leading causes of urinary incontinence in elderly patients. Other potentially reversible causes include medications, excess urine output, alcohol, delirium due to any other cause. Medications that may commonly cause urinary incontinence include alpha antagonists, like because they cause urethral relaxation, anticholinergics, opiates, CCBs, and many other things. Reversible causes of urinary incontinence are the diapers mnemonic, right, which was right here. So this is delirium, infection, atrophic urethritis or vaginitis, some medication, depression, excessive urinary output because of unmanaged diabetes, restricted mobility, stool impaction, a bunch of things, all kinds of things. This mnemonic doesn't really do the job for me. I just know the things that can cause you to have urinary incontinence. Right? These are some things that can cause urinary incontinence. For her, as older adults often lack typical signs or symptoms of a UTI, urinalysis with culture should be obtained routinely. Once infection is excluded, additional testing based on clinical findings that suggest other etiologies can be done. Right? So that's really all this was for her. Very, very realistic clinical knowledge type of question, right? Not a step 1 question. This would be really hard for most step 1 students, this type of question. Next one here, 54-year-old postmenopausal woman comes to the office due to involuntary loss of urine. She's unable to hold her urine during the day, but has no loss of urine while sleeping. Okay, so involuntary loss of urine tells you right away it's incontinence. She's unable to hold it, that is incontinence. but there's no loss of urine while sleeping, so that rules out this answer choice. Because if she had overflow incontinence, then her bladder would be full. She would have no urge to pee because she can't pee. It's not working. Her detrusor muscle is not working. And then when she would go to bed and she's a little unconscious at that point, she would leak overnight. But she doesn't have that. So she doesn't have overflow incontinence, so we can rule that out. She is sexually active but has been avoiding intercourse for the past few months because she sometimes has leakage of urine during intercourse. She also loses urine when laughing or coughing, so that gives away the diagnosis of stress incontinence. She has no chronic medical conditions, takes no daily meds. Her only surgery was a cesarean delivery at age 30, complicated by pyelonephritis and preterm labor, no big deal. Vital signs are normal, BMI is 38, so she's obese. Pelvic exam shows dribbling of urine when she coughs. A post-void residual volume is 30 milliliters, which is actually not so bad. The urine analysis shows no abnormalities. What is the most appropriate treatment for her incontinence? So she's 54. Now, we avoid medication and we avoid surgery as much as we can. So you're going to look for answer choices that avoid that, and they have a mid-urethral sling as an answer choice, and that works. That's perfectly fine. Her issue is that weakened pelvic floor muscle. So every time she coughs, she urinates. So what do? You need to strengthen this. How can you strengthen this? You could do exercise for the levator ani, or you could connect the pelvic sling with that picture that I had just posted here a while ago. Right? That sling would do the job. It would tighten this, pull it back, and every time she sits, the sling weakens, then she can urinate. But when she's standing and not really trying to urinate, she won't leak. Right? And then we would have to tell her to make sure she goes urinate regularly so that she doesn't urinate when she just sits down because she wants to sit down. Right? And that's going to be very important for her. It's not a bad question, really easy, super straightforward. They go on to tell you conservative management is Kegel exercises which strengthen pelvic exercise and that sling. Right? Otherwise, you don't want to go into the other answer choice of antimuscarinic agent. So an antimuscarinic agent would stop acetylcholine. Acetylcholine makes you pee, so she would no longer be peeing. So with acetylcholine being turned off, you would stop the M3 activity of the detrusor muscle. But her issue is not that the detrusor muscle is working really hard. It's not that the detrusor muscle just starts contracting. That is urgency incontinence, where you have a hyperactive muscle. You see how brolic it is? This is a great picture because they actually made this very thick here compared to the normal one. Right, so this patient with urgent incontinence would necessitate antimuscarinic medication to stop her from peeing. All right, so you can see the differences here very nicely. Good picture in the CKU world right here. All right. This question here is about a urethral diverticulum, which is one of the differentials for some of the other things we just looked at today. 33-year-old woman. So notice already we have a drastic change in age group. Most questions we were looking at were women 50 or above. Now we have someone 33. And the only question right here where the woman wasn't over 50 was this one, but it was because it was a young woman with multiple sclerosis, which effectively makes you like someone who's 80 because your nervous system isn't working that well. Right? So that's the only time it's a young woman, because there's something else there that is really messing up your system. So 33-year-old woman comes for evaluation of a vaginal mass. She first noticed the mass 2 weeks ago after having pain during intercourse. She has avoided intercourse since, but the mass is still present. She has had 4 sexual partners in the last year, uses combination oral contraceptives, so there's a chance she may not be using condoms. She had 3 term vaginal deliveries in her 20s. Her largest baby was 10 pounds, so that's pretty big. So these are all things telling you that there may be a chance for a fistula formation or something like that, where the big baby came out, and as we discussed earlier in this video, you had to do an episiotomy and you connected the vagina to the bladder or the rectum, usually the rectum. So it could be relevant, but probably not, because remember with the episiotomy, as I said before, the big baby that's trying to come out won't be able to come out, so you can do an incision right here. And when you make that incision is often deeper, like that. You cut in this way to make this opening bigger, and if you cut in too deep, you can connect, as you can see, these 2 areas, right? So now every time poop is coming out, your rectal sphincter will stop the poop from coming out, but then it can just come out of the vagina, and that's going to be really bad. That doesn't look like what her problem is. She had an abnormal cervical cancer screening 2 years ago, but a normal follow-up colposcopy. So we can just completely erase that line, right? This is here just to confuse you. But you can see, and we just looked at HPV topics, If she had an abnormal cervical cancer screening, but then you did the colposcopy, which is the next step, and it all looked fine, then she doesn't have cervical cancer. So that sentence is useless. Vitals are looking okay. BMI is good. On pelvic exam, there's a 3-centimeter mass on the anterior aspect of the vaginal wall that does not change in size with the Valsalva maneuver. That means that this little mass is not related to the abdominal cavity, so it's not prolapse. It's not prolapse, because any prolapsing thing that's coming out of the abdomen would come out even more when you try to do the Valsalva straightening. They go on to then say that the mass is definitely tender to palpation and expresses a purulent urethral discharge, which means that it may be getting infected. So the only thing that can be in your anterior urethral area has a risk of getting infected is this thing, right? This is where they're touching. So they ask you what's the most likely diagnosis in her, and only 37% of people got the correct answer, a urethral diverticulum. 52% of people chose an answer choice that is somewhat respectable, but not really. Excuse me. A Bartholin gland abscess. Now, we looked at the Bartholin gland earlier. The Bartholin gland is something that is over here on both sides, and if there's an abscess with that thing, it'll be big. But it'll be on the sides, not where they described it. They described it in the anterior aspect of the vaginal wall, not even the labias, right? Not even the labia minora or something, but the actual vaginal wall like this. So that's the urethral diverticulum. Her anterior vaginal wall mass is due to a urethral diverticulum, an abnormal localized outpouching of the urethral mucosa into the surrounding tissue. It's a very specific one-on-one topic. When you see this, this is the answer. That's it. Right? Really straightforward. On top of that, anytime you ever had an answer choice of abscess, wherever the abscess is, chances are the patient would have some kind of fever, really bad irritation, something like that. A lot of pain, not just a little bit. Now, she does have a lot of pain, and most of this question does match enough things to be able to pick Bartholin gland abscess, but the anatomical position of the abscess or mass gave away the fact that it's not Bartholin gland abscess. All right, so that's all this question was. Very good question for that topic itself. Here we see a question where you actually pick the answer choice, voiding diarrhea. Super annoying. I can't really ever imagine I'm going to tell my patient to take avoiding diarrhea. That sounds pretty dumb to me, to be entirely honest. 48-year-old woman comes to the clinic because she is urinating all the time. She initially had some leakage of urine with sneezing or coughing, but now she leaks while walking to the bathroom. So when I see this question, I'm not sure what she has anymore, right? Because if it was just the sneezing or coughing, then that's stress incontinence. But now she leaks while walking to the bathroom. That's urge incontinence. So it could be mixed incontinence, right? We've seen this. Mixed incontinence is features of both stress and urgency, right? So every time you cough, you pee, and sometimes you just end up peeing on the way to the bathroom. So that must mean that someone who has a weak muscle here, this is weak, and then also they have this being too strong. So both of those things being combined means you're going to be peeing all the time. And that's kind of what's happening with her, urinating all the time, right? So the question, and clinically the picture fits perfectly, and you guys should be able to see that. She sometimes has an intense urge to urinate, but passes only a small amount when she tries to void. That now confuses you into even thinking, is this also overflow incontinence? But it isn't. She now wears a pad every day and plans her social outings based on bathroom access. She has had no dysuria or hematuria. She had 2 vaginal deliveries in her 20s. She drinks alcohol socially, has coffee every morning, drinks lots of water throughout the day. This part is a little concerning. Drinks lots of water throughout the day. As someone who drinks a lot of water throughout the day would definitely be peeing a lot throughout the day. So that's something that you want to kind of pay attention to. Remember back in step 1, renal, we also saw this thing called psychogenic polydipsia, right? Which we had to differentiate from central and nephrogenic diabetes insipidus. Psychogenic polydipsia is you just drink a lot of water, so you pee a lot. You don't have diabetes insipidus. When asked which urinary symptoms are most troublesome, she is unsure. What is the best next step in her management? Now, this is the only time you pick voiding diarrhea as an answer choice. So avoiding diarrhea, when I look more into it, basically says, what did you do all day in terms of drinking water? And then how many times did you pee? And did you have any incontinence before going to pee? How was that urinating session? Right? This is basically you really listing out everything that's happening to you, and that's kind of what you would do. 30% of people though chose urodynamic testing, which I thought was the correct answer choice because it makes sense to me. Right? She's got something weird going on with her urination, so I need to see the dynamics of her urination. When is she urinating? How is she urinating? How is it all happening? And I wrote that here. I would think urodynamic testing also, right? But that was the wrong answer choice. It was avoiding diary, which may be just a personal issue of mine that I really don't understand why I would ever fucking pick this as an answer choice, but it is what it is. Right? She has mixed urinary incontinence based on the stress and urgency symptoms. That was obvious. Urinary incontinence is common and may cause significant distress, as in her, who now wears a pad daily, basically has to wear a diaper. And even when she goes out, she has to pick a place that has easy bathroom access. So that's kind of difficult, right? Imagine going to like some kind of big outdoor party. Then it might be difficult to access a bathroom there. Initial evaluation of mixed incontinence includes avoiding diary, which tracks fluid intake, urine output, and leaking episodes in order to classify the predominant type of urinary incontinence and determine optimal treatment. Right, so they don't teach you that in step 1 at all. In fact, even I don't have notes here for that. Right? Voiding diary. This is right here. You would put voiding diary. You want to get this down. And that is the treatment here. Why? Because you need to figure out what is the predominating thing here. Does she have more problems with the stress incontinence, or does she have more problem with the urgency incontinence? Thankfully, though, both of them are kind of sort of treated with the same kind of thing. Right? Both of these issues were problems where either this area was weak or this was too strong. So what do you need to do for her? Well, you need to weaken this and make this stronger. So you would tell her to do Kegel exercises to make this sphincter stronger, and you would stop this thing from contracting, right? So this thing contracts because of parasympathetic output, which is for urinating, rest and digest. So you would give her an anticholinergic, right? So oxybutynin for overactive bladder is the mnemonic for that. You would give her an anticholinergic that would stop the M3 receptors on this detrusor muscle, and she should be okay, right? But again, if her major problem is stress incontinence and you give her oxybutynin, you will stop the urge incontinence, but every time she coughs, her weak sphincter will still let her leak the urine, right? So that wouldn't really solve all her problems in that case. So you need to figure out what is the bigger issue, and that's why you would pick this terrible topic and concept of avoiding diary. Right? So you make sure you get that down. Had she answered, right, when we asked her, when asked which urinary symptoms are most troublesome, has she said that the coughing part is the more troublesome aspect, then we would target most of her treatment towards the stress incontinence, right, where we would try to strengthen her external sphincter by telling her to do Kegel exercises and make her levator ani pelvic floor muscle stronger. Urodynamic testing involves measurement of bladder filling and emptying, urine flow, and pressure. This is typically reserved for patients with complicated urinary incontinence, which are people who do not respond to treatment, or those who are considering surgical intervention. Basically, it's never the correct answer choice. Right? It's only the correct answer choice in the very end, right when you're about to decide doing surgery. Right? So again, great question because it teaches you something very meaningful, and you get it down, and you now know where you pick voiding diary as an answer choice. These last two questions here are very straightforward questions on different topics relevant to what's coming up next. Right, so we're seeing the 3-year-old for the topic of pediatric gynecology, and then a 19-year-old. So the 3-year-old girl, this is a 3-year-old girl brought to the office by her mom for vulvar pruritus. So she's got an itchy vagina. For the past 3 months, she has been scratching her vulvar region through her clothes day and night. Very common thing for a 3-year-old girl. There have been no changes in soap or laundry detergent, and that's why it is common. It's usually because they tried a new laundry or detergent, or they tried some kind of new well, actually, yeah, these are so new thing to shower with or new thing to clean your clothes with, right? So that's soap or laundry detergent. These are the changes that often lead to allergic reactions causing itchiness. And she does not have pruritus over other areas. She has been toilet trained for the past year and has had no accidents, hematuria, or abnormal vaginal discharge. No chronic medical conditions. Development is great. Vitals are normal. Height and weight are good. Pelvic exam, the vulva is excoriated and there is an adhesive ridge fusing the posterior. So the excoriations are obvious because she's scratching it so much, but adhesive ridge fusing the posterior labia minora in the midline. That is not normal. Right? So there's something that is fusing her labia minora, which basically means that her labia minora didn't open up all the way. There's no labial or vulvar atrophy and no plaque formation. So what they're describing in this question is basically what we're seeing here. I made those circles earlier. But we're basically seeing this line right there. So you see how this is normal? Now she has this line, which is probably getting inflamed, right? That adhesion is getting inflamed and causing itchiness. So what's the next best step in management? And most people were very confused, but the correct answer was just to give her an estrogen cream. Right? 25% of people chose antifungal cream. 10% of people chose to give her trichloroacetic acid, which many of the other students I showed this question to later, didn't even know what that was for. So trichloroacetic acid is actually for HPV. It's to treat warts. Right? If you forget what this is, just remember the tri, T-R-I, for the three letters H, P, and V. Trichloroacetic acid gets rid of the warts. That was definitely not her problem, right? So there was no reason to pick this answer choice. These people were definitely confused. And that was the case with most people who I showed this question to after. To anytime I'm tutoring someone and I go through this question with them and I list out these three answer choices for them, most people have no idea what the hell trichloroacetic acid is. So that should now hopefully stick to you. She has vulvar pruritus and fusing of the posterior labia minora consistent with labial adhesion. A fused labia minora, typically affecting prepubertal girls with peak incidence at age 2 to 3 like her, due to low estrogen production. That's all this was. Other contributing factors may be chronic inflammation due to poor hygiene, skin irritation, trauma, but she didn't have any of that. Mild asymptomatic adhesions require no treatment because up to 80% resolve spontaneously and it will just open up. Patients with complete adhesion or symptomatic partial adhesion like her are treated with topical estrogen as first-line therapy. So the way you should imagine it is that you're just putting woman cream on her to make her more womanly. That's all it is. Right? Female cream, estrogen cream. It's gonna further speed up the puberty in this specific area and allow that adhesion to kind of go away. Worst case scenario, if nothing helps and this is still there, then you have to surgically open this up. That's the second answer choice you would pick. It was not an answer choice here. Last question is this one right here. 19-year-old woman comes to the office due to continuous vaginal discharge. She has had clear, slightly malodorous vaginal discharge for the past few weeks, but no pelvic pain, dysuria, or pruritus. She's 6 weeks postpartum. So she just gave birth 6 weeks ago from a vaginal delivery of a stillborn male infant after 3 days of labor and 4 hours of pushing. That's unfortunate, right? So the baby was born dead. She had no prenatal care and delivered at home. So, I mean, that kind of explains why they may have had a stillborn male. So delivered at home is critical because now you start thinking they might have made some mistakes and the lack of medical care may have led to some issues. Vitals look good. Pelvic exam shows a well-healed 3rd degree perineal laceration. So this perineal laceration basically tells you that when they were trying to deliver the baby, they made that incision here. Right? They made an incision here, kind of like an episiotomy, to open this up more to get the baby out. And that 3rd degree laceration is so big that it can often actually reach the sphincter. Right? So it's going to be a problem. That may be relevant to why she's having this issue. And as I said earlier, that if you do that, if you make that cut, then you can see what I just did. I connected the opening of the vagina to the rectum. Right? So now, although feces would come out this way and your rectal sphincter would stop it from coming out, because you have this fistula, basically, feces can come out this way, non-stop, all it wants to. Which kind of fits with her scenario of having a malodorous vaginal discharge. On speculum exam, there's small red area of granulation tissue on the anterior vaginal wall. So granulation tissue is obviously tissue that you form when you're recovering from a wound. Cervix has no lesions and there is a pool of clear fluid in the vagina with a pH of 6. pH of 6 is not vaginal fluid and the vagina is very acidic. So that's something concerning. What would establish the diagnosis? And the correct answer here was something called the bladder dye test, which is the only reason I put this question here. Because the diagnosis is pretty obvious. She clearly must have a connection somewhere, but since her her discharge is clear, they just told you right now that it's clear fluid, then this slightly malodorous vaginal discharge must be coming from the other way, right? So in the various connections you can make, the most common one during a laceration during delivery is this one. But the other thing that can happen is the other way, this way. So you see this fistula would mean that urine in the bladder, which would normally come out in this direction and your urethral sphincter would stop it, now can freely come out from this fistula all it wants to, causing vaginal leakage of clear malodorous fluid. So her diagnosis was vesico-vaginal fistula. This diagnosis became very obvious because the whole time in this question I was thinking it would be a recto-vaginal fistula, but then when they described the fluid is clear and not tan brown, that's the other way they can describe it, then it must be from the bladder. So this bladder dye test, what this does is you inject some dye into the bladder and then you don't let them pee. And you'll see that the fluid that comes out of the vagina, even though they're not really trying to pee, is going to have the same color as that dye you put in their bladder. So that tells you that something is coming out of the bladder, but it's not coming out of the usual pathway you would urinate from. So that proves that there must be a fistula like that. A small connection, all of which occurred because this 19-year-old woman for some reason decided to have delivery at home, and it didn't go well. It didn't go well at all. Stillborn male and has a vesico-vaginal fistula now, which definitely has to be fixed. So what you would do for this is surgical correction, mainly just stitch it all tight back together. Right? So treatment is surgical repair. That's it. Very easy question, but a lot to learn. It's a great question. There's a lot to learn. We definitely, I hope that I made it very easy now to see the types of incontinences, master how to tackle them, understand the ways of treating them, the fact that these two go together and this one is a separate one, right? And that they can occur together in the mixed version. We saw the voiding diary and how you use that in the mixed version. So we knocked out urinary incontinence. Never need to come back to that topic again. You should be able to kill any question on that. And then we knocked out pelvic organ prolapse, which while we knocked it out, we talked about the vesicocele, the cystocele you can get, the bladder issue, and the rectocele you can get here. Right? This image is showing you procedentia, but we looked at it in step 1 on another page where the same kind of thing can occur with this kind of prolapsing in this direction, right? And the urethra would be up here. This image itself is showing you the prolapse of the urethra. Do I have I don't have a rectal one on this page, but we looked at it in the step 1 book earlier. All right, so that's it for this topic, and then in our next topic we'll move on to pediatric gynecology tomorrow morning. Thanks a lot for joining, guys.